Hi, my name is Sheena. I'm a case manager at Chilliwack Home Health, and I have had the great opportunity to explore care management to refocus my role as a case manager in Chilliwack Home Health. And this is my presentation to show you my interpretation of care management and the success that this program has given us. And what I'm finding is that I'm able to use my time differently and approach my workload differently. I'm finding that I can visit with a client for an hour, encourage the client to develop a plan as to what they want to do, and then I'll revisit with them, and a second visit, a telephone call, may only take a half an hour or at the most an hour. So overall it would seem that I'm not using more time. I'm possibly using the same amount of time or less time to complete the conversation with the client. With care management, we totally switched gears and started from a different place. The day that the file comes to me, I make telephone contact. This is a way of reaching out to the client and helping them feel connected. They are anxious, they don't understand home health, and this is a way for me to make contact quickly to them. We set up a date that I would be visiting with them based on their priority and what information I already have. The day prior to my scheduled home visit, I phone the client, remind them who I am so they can anticipate my arrival. On the day of the home visit, I go prepared to go forward with a RI assessment. I take my laptop, it is preloaded, begin a conversation with the client. I find that not having my laptop on my lap initially it creates a different feel for the room. It's more of a comfortable conversation between myself and the client, leaning in and listening to what they have to say. Then we work into a conversation about what is actually available for them to support them living in their home environment. There seems to be quite a lot of confusion about what is actually available for our clients. When they say to me, oh, I want to go into a home, we need to have quite a long conversation about what that actually means. Why do they want to be in a home? What is it that makes them feel that they can't live where they're living? To direct my conversation, I often use the resource guide, and this gives me an opportunity to actually sit close to the client and hold the pamphlet, and we have this ongoing conversation about what is actually out there. And sometimes it's interesting watching them take in this information and start to figure out that maybe they can live in their home. Maybe they don't have to go to a home. There's a couple of tools that I use while I'm having the conversation, and one of them would be the, I guess we call it a bubble diagram. It asks what their health goals are. They might say to me, well, I really would like to live on my own. So one of their goals might be to live independently. The form also asks what their strengths are. And sometimes I listen to what they say, and I use talk back to say back to them what I've heard them say. They might say to me, well, you know, I've still got my marbles. That's a strength, that they have the capacity to make decisions. As the conversation evolves, I start to make notes in the bubbles. Things that I might write in these bubbles are a fear of the stairs in their home, or afraid of falling in their bathtub. And I very casually have this alongside me. As the conversation evolves, we start to fill out these bubbles. I often say to the client, while we've been talking today, you have said to me that you're concerned about your stairs in your home. What is it that you think you can do to manage your stairs? Do you have an alternate plan? Are you thinking of moving? Do you need to put a ramp in? Another very common issue is fear of falling in the shower. So then I'll explore that with them and say to them, well, do you have any equipment? This is an opportunity for me and the client to get up out of our chairs, to move around their home, to take a look at what obstacles there are. We may talk about rugs on the carpet. We may talk about the safety on the stairs, the handrail, or in more detail in the bathroom. We'll look and explore whether they have any handrails, bench seats, handheld shower, this kind of thing. And quite often the clients don't have this equipment. So then we move into, well, if you had a bench in your bathtub and you had a handheld shower, maybe you would feel confident in having a shower on your own. I'll give you an example of a client that was referred to me with acute back pain. I had made contact with the client in my usual manner, phoning them and setting up a date to go visit with mum, and she seemed to be fine with that. However, the daughters were very anxious, not happy. They felt overwhelmed with caring for mum. So when I actually got to visit with the client, we followed the usual process of going through the resource guide. The client actually has chronic back pain. This is something that she does have to learn to live with. So part of my care management was, initially was talking about what resources are available. We talked about Meals on Wheels so that she doesn't have to stand at the counter and chop her vegetables. We talked about a mobile hairdresser that would come and fix her hair so she would get her hair washed. We talked about Lifeline, a button that she could push to call on her daughters if she needed some help. We talked about the foot care nurse. This client's she's able, but she's scared to reach down to her feet in case she gets stuck or if her back starts to bother her. Then we explored what she could do on a day when her back is really hurting her. What kind of things could she do to help herself? So we talked about the chair that she sits in, whether it was an appropriate chair, how she sits in her chair, whether a footrest would ease some of the pressure. We explored the medications that she has in her home. She had various over-the-counter medications, and she also had some Robaxacet. She was under the impression that this was a heavy-duty medication that really should only be taken when absolutely needed and nothing else to relieve her pain. So we actually read the package together. The two of us read the package, and of course it said 1 to 2 tablets every 4 hours. She said, well, I thought I could only take 1. So I said, well, you know, if your back pain is really hurting, then you could take 2. We talked about whether she should have food in her stomach before taking the medication, the possible side effects of taking the Robaxacet, and what to do if still she had pain after taking the Robaxacet. A follow-up appointment with her GP was very important for her. She needed to have another discussion with the doctor as to what was the intent of the medication. Was it a long-term medication? Was it a short-term medication? Was it for the acute phase only? Or what are we going to do for her chronic pain? By the end of the conversation, I felt that the client felt more confident with the prescription that she had, how to use her prescription, and how to manage her day-to-day life within her condominium. We had explored various opportunities for her to access resources that would lessen the burden on her daughters, who had at this point felt that they needed to move in with mum and take care of her. The client, of course, was more than happy to have her daughters do most things for her. So we talked about that, about how the client could let go and regain the independence and manage her chronic pain at the same time. So visiting with the client a couple of times and having conversations, we did develop the health improvement plan. So the items that we had identified on the bubble plan, this one here, were then transferred to the health improvement plan. This is a 2-page document. It gives me the opportunity to leave one with the client. I feel like this gives me a presence in their home after I've left. So on the far left we write the topics. So for this client we had pain management that was primary. We also had foot care nurse and Lifeline, all different topics here. For my steps, I try to encourage the client to follow through. So I might write here, from the client's perspective, I will explore the possibility of having a Lifeline, or I may meet with the foot care nurse to see what service they provide. In the case management tasks, this is where I write that I'm providing resources. I'm providing the service that a case manager can do. I'm providing information, resources, contact telephone numbers. And then the review date, quite often 1 week, 2 weeks. I'll either plan to make a telephone call to the client or another home visit, depending on the success of my conversation on this day. Some of my clients benefit more from another face-to-face conversation. This date is added to my Outlook calendar so that I can track when I need to follow up with a health improvement plan. So if I'm contacting them by telephone for the follow-up, I ask them, do they have their health improvement plan? If the item on the health improvement plan has been dealt with, then I try to encourage them to see that they have helped themselves. If they've yet to explore the possibility of a lifeline, then I might ask them to reconsider looking at the lifeline and what the benefits are for that client. What I'm finding with my care management model of care is that I'm visiting with more than one client per day. On some occasions I'm visiting with 3 or 4 clients per day, and I'm finding it important to capture the essence of the conversation as soon as possible. I'm finding that this is really helping me document appropriately, accurately for my clients in a timely manner. I'm utilizing my tablet and a Word document, and after visiting with a client I will find a space in my car or somewhere and I'll start to document a home visit with the client, bubble diagram and health improvement plan completed, paper file available on file, and a few short sentences that would, anything that is required to complement the health improvement plan, but not rewrite the health improvement plan or the bubble diagram. They will be there for reference in the future in the paper form. To support the care management model of care, we do have clinical practice guidelines that give us permission, shall we say, to discharge clients that no longer require our service. So with the client, the example that I gave you, after visiting with the client twice and phoning her and phoning the daughters, I was able to say that I had successfully completed my service for that client, and the client was discharged. There was no RI assessment to be done, and the financial assessment did not have to be approached. In the last 4 months that I've been following this method of practice, I would say that I am very encouraged by what I'm able to do, the difference that I'm making, the impact that I'm having on my clients, and the success that my clients are showing for themselves. A realization that they can still remain independent. It becomes very empowering for myself as a case manager and for my clients.